Dr. Gary from Nagoya University.
Good morning. Thank you very much, Dr. Imamura, and thank you, JSMO, for providing this opportunity to present our research findings. The topic of my presentation today is loss of muscle mass associated with the long-term use of mTOR inhibitors. This is our COI. Sarcopenia is the decrease in muscle mass. It may or may not be associated with decrease in adipose tissue. Muscle mass has no relationship per se with body weight or body mass index. So a patient with normal body weight and normal BMI can have sarcopenia. And sarcopenia is important because it forms a component of cancer cachexia. And it has also been known that low muscle mass is a predictor of drug toxicities and poor prognosis in a variety of cancers. On the other hand, some targeted cancer drugs are known to change the body composition. For example, sorafenib causes loss of muscle mass, while vandetanib and selumetinib, they increase muscle mass. And this change in muscle mass is believed to involve the PI3K-AKT-mTOR pathway. However, there is no data on the change in muscle mass due to the use of mTOR inhibitors. So we did this study with our primary objective to assess the change in muscle mass during the long-term use of mTOR inhibitors. And we defined long-term as a use of drug for at least 6 months. And our other objectives were to assess the change in other parameters of body composition like adipose tissue and body weight, and to compare the time to treatment failure, TTF, between the sarcopenic and non-sarcopenic patients at baseline, and to test whether serum albumin and CRP could predict the change in muscle mass. This was a retrospective study done at Nagoya University Hospital and Japanese Red Cross Nagoya Daiichi Hospital from 2010 to 2015. And our eligibility criteria was the use of mTOR inhibitor, everolimus or temsirolimus as a single drug for at least 6 months, and the availability of CT scans of abdomen at the third lumbar vertebrae within plus minus 1 month of the start and the last dose of drug. Body composition is classically measured using the DEXA scan in the appendicular skeleton. However, in oncology, CT scan-based measurement at the level of L3 vertebra is taken as gold standard. And with the help of a special software, we can segregate the body composition parameters using CT Hounsfield units into subcutaneous adipose tissue, visceral adipose tissue, and skeletal muscle. And the area thus obtained, if divided by the square of body height, gives us the L3 skeletal muscle index. And we have cutoff values of skeletal muscle index to differentiate patients into sarcopenic or non-sarcopenic, and it's 38.5 for females and 52.4 for males. And we also have a formula that gives us the lean body mass in kilograms using the same muscle area. So moving on to the results, out of 75 patients who took mTOR inhibitor in this period, we had 20 patients who met our eligibility criteria of use as a single drug and use for at least 6 months. And of them, 60% took everolimus, 40% temsirolimus, 90% of the patients were of renal cell cancer, 80% were male, median age was 65.5. The mean duration of therapy and CT interval was similar. There were no obese patients. 25% patients were underweight, 10% were overweight, and the percentage of patients with sarcopenia at baseline was 60, and this increased to 75 after the use of the drug. And the median baseline L3 index, skeletal muscle index, was 50.5 for males and 30.5 for females in our population. So this table shows the difference in various components of body composition after the use of the drug compared to baseline. And from here we can see that there is no change in body weight, there is no significant difference in adipose tissue, but there is a significant fall in muscle mass, muscle area, skeletal muscle index, as well as lean body mass with the use of the drug. And this decrease in body mass was as much as 4 kilos. And this is the CT slice of a representative patient. In case of this patient, we have the subcutaneous adipose tissue in blue. It has decreased by 52%. The visceral adipose tissue in yellow, it has also decreased by 52%. And the skeletal muscle, our primary concern, has decreased by around 19%. But the body weight has decreased by only 7%. And we also checked whether any parameter was correlated with the fall in muscle mass. And the only significant association was with baseline SMI. So a patient with low baseline SMI has low decrease in muscle mass. That means a patient who has low amount of muscle mass at baseline, his fall in muscle mass will also be low after the treatment. And this is the Kaplan-Meier for the time to treatment failure, and we can see that there is absolutely no difference between sarcopenic and non-sarcopenic patients. So our study shows that the long-term use of mTOR inhibitors significantly decrease the muscle quantity, but it does not affect body weight and adipose tissue. And the amount of decrease in muscle mass, it was related to the baseline muscle mass, and time to treatment failure was not related to the sarcopenic status of the patients. And we had the inclusion criteria of the use of drug for at least 6 months, and we also found that there was no loss of body weight. So these two findings rule out cancer cachexia as the cause for the fall in muscle mass. It is probably due to the drug and not due to the disease. And we saw that chronological assessment of muscle mass is important during treatment with mTOR inhibitors because muscle loss cannot be predicted by body weight or BMI measurement alone. So in conclusion, the long-term use of mTOR inhibitors leads to loss of muscle mass. Thank you.
Thank you for the presentation. So we had a discussion. Do you have any comments, any questions? Please.
I'm Daisuke from Cancer Institute Hospital. Thank you for your spectacular presentation. I have one question about it is specific phenomena about mTOR inhibitor or normally cytotoxic agents?
Thank you very much, Dr. Takari. Until now, there has been no report with cytotoxic drugs. The only report is with sorafenib, vandetanib, and selumetinib. And out of those 3 drugs, sorafenib decreased muscle mass, vandetanib and selumetinib, they increased muscle mass. The hypothesis for all those drugs was some involvement with the PI3K-AKT mTOR pathway. So we checked whether there was any association with mTOR inhibitors themselves.
Okay, and when we observed the skeletal mass decrease, do we need the change of the dose of drugs?
We do not know that yet. We know that low muscle mass is a predictor of drug toxicity.
Toxicity?
Yeah, and it can also be a poor prognostic factor, but we do not have yet any intervention as to how to combat the loss of muscle mass. A couple of months ago, there was a publication in Lancet Oncology that a new drug called enamorelin can prevent the loss of muscle mass. However, there is no data yet on any drug which can prevent the loss of muscle function.
Thank you very much.
Thank you. Thank you so much.
Thank you. So, the other questions and comments? So I have one question. What did you define as long term?
That's a very good question. And we defined as the use of drug for 6 months. That's very arbitrary. That's not a well-defined definition. But our hypothesis was muscle mass can be decreased by cancer itself as well as due to the drug. So in order to be sure that it is due to the drug and not due to the disease, we took long-term use of 6 months because a person who is on the same drug for 6 months, maybe he does not have progression of disease, so maybe the fall in muscle mass is not due to cancer, probably it is due to the drug.
Thank you. Any other questions? Okay, thank you for your presentation.
Thank you very much.
So we move to next presentation. The second speaker is Dr.